Welcome to the Voice of Florida Architecture. I'm your host, Rhonda Hammond, AIA. In launching this podcast, our purpose was to educate the public and elevate their understanding of the vital role architects play in shaping our built environment. Architects contribute significantly to the quality, safety, and sustainability of the spaces in which we live, work, and gather. This platform seeks to promote a broader awareness of the profession's value, not only to community members, but also to local officials, policymakers, and procurement agents. By showcasing the breadth of architectural impact, the podcast aims to foster appreciation for the profession and encourage greater engagement with the architectural community, including those not yet affiliated with the AIA. AIA Florida has a strategic partner in this mission, the Florida Foundation for Architecture. It is their mission to promote the value of architecture to the public. During our second season, in collaboration with the foundation, we launched a series entitled Architecture and You. To tell you more about this series and to introduce our special guest, we have with us today the Foundation's 2025 Chair, Mr. Stephen J. Hruby, AIA. Good morning, Stephen. Welcome. Thank you for being here today, and thank you for all your efforts in bringing Architecture and You to our listeners.
Well, thank you, Rhonda. I'm very excited about this series, as you know. We at the Florida Foundation for Architecture are so pleased to be joining you on your mission of promoting our profession. Our vision for this series is to explore with our viewers spaces we live in, work in, play in, and maybe even dream about. We'll be diving into a topic that affects all of us in so many ways, even though we might not realize it. And that is the value of architecture and architects in our daily lives. When we think about architecture, we might picture famous buildings or eye-catching designs, but architecture is so much more than that. It shapes our communities, influences how we feel in spaces, and helps us solve real-world problems, from housing and climate change to safety and public health. Architects don't just design buildings, they imagine better ways for us to live together. Whether it's a local library, a hospital, a school, a park, or even your own home, there's a lot of thought and care and skill behind those spaces and how they're made. In this episode, we'll be exploring an example of why architecture matters, what architects really do, and how good design can improve our lives in so many ways that we have not expected. Today, we're having a conversation with Bill Hercules, FAIA. Bill is an award-winning architect who empowers healthcare leadership teams to shape their places of care. Bill has planned and executed architecture totaling 36 million square feet at a present value of $14.5 million. Bill founded WJH Health, a global consultancy, to help resolve design issues for places of care at their nexus of mission, performance, and experience. Bill's passion for applied learning has elevated him to be the only healthcare practitioner to achieve triple fellowships in related organizations. He is a fellow in the American Institute of Architects, the American College of Healthcare Architects, and the American College of Healthcare Executives. He is a global expert in healthcare design with almost 190 printed and spoken publications that have been frequently quoted in industry and popular press. He's an officer in AIA's College of Fellows Executive Committee and will serve as its chancellor in 2028. He's the past president of the ACHA, and he recently led the AIA's Architecture and Well-Being Study for the National AIA Strategic Council. That initiative led to the passage of a national AIA Health and Well-Being Policy Resolution. He was invited to serve on 2 international COVID rapid response task forces, and he is currently AIA chair for the AIA AGC Joint Committee to deepen the links between design and construction. He also co-founded BPR Lab, an award-winning interdisciplinary international think tank dealing with issues at the nexus of bioethics and architecture. He co-founded the Advanced Clinical Design Institute, which is an immersive certification program for high intensity healthcare environments. Bill holds a Bachelor of Architecture degree from Washington University, my alma mater, a master's degree from Boston Architecture College, and a postgraduate certificate in healthcare from Harvard Graduate School of Design. A very impressive resume indeed. So welcome, Bill.
Well, thank you, Steve. It's great to be here.
Bill, we want to have a conversation about healthcare environments, and these are spaces that we experience in our most vulnerable and stressful times in our lives. And I think that they are extremely important, and they have huge impact on the public and all of us. So at some point in time, we will all experience one of these spaces or many of these spaces. Throughout your career, you have been involved in a wide variety of healthcare projects in both large and small throughout the world. What strategies and techniques have you and your colleagues used to make healthcare facilities a place that supports the health and the recovery of the patient and where patients feel at ease?
Well, Steve, that's a very loaded question with many questions embedded in it. So what I'd like to do maybe is offer a little bit of context to why this matters to Floridians at all. Up until last year, Florida had the highest percentage of residents over 65 of any state in the country. And why that matters is people that are over 65 generally consume healthcare services more than any other time in their adult life. Right now, Maine actually overtook Florida as the state with the highest percentage, but Florida certainly has a number of seniors. So what I'd like to do maybe is offer a little bit of context around why we're even talking about health, and just to offer maybe a working definition of what health is. This is how the World Health Organization defines health. It's essentially the state of nirvana. Everything is full and complete. And it used to be that health was defined sort of by the antithesis, which is just, well, I don't have a disease. Oh, okay. But this is a pretty reasonable working definition here. Let's use that as we kind of move forward. Those of us that are architects understand this famous quote by Louis Sullivan. We learned it in school, and its context was actually kind of interesting. He wrote a very long essay in the Lippincott journals a long time ago, and he was talking about high-rise design. And he was Frank Lloyd Wright's mentor, and he had a very significant place in the architectural space. But he was talking about how nature develops things. And he was talking about natural forces and a variety of other things in the context of this essay. And he came up with this phrase, form ever follows function. If you're talking about a natural system and you're talking about God's creation, of course, you have no constraints at all. You could sort of do whatever you want. And you set things up and they sustain themselves by virtue of their design. But I've come to believe that while form does follow function in a natural sense, it's really follows finance more so in a more practical and pragmatic kind of way. So what I'd like to do here is talk about something related to the finance of what health systems are all about, because of course we operate in a system. Since the mid-1960s, we've had semi-socialized healthcare, and that's been a political battle actually since before the Truman administration into FDR moving forward. There's a long and varied history associated with the influences of all of those things. But it is a financial construct that is ultimately taking care of us or supporting our care, in addition to the very tactile, hands-on kinds of things. And the systems, the health systems in particular, that are taking care of us, operate on relatively thin margins overall. During the COVID years, this chart was completely below the line for about 16 months, meaning that they were operating on reserves generally during COVID, which was not a very healthy state. Things have stabilized, sort of back to normal. But the financial pressures are very real. Most healthcare system executives are continuously lobbying their representatives and senators in Washington for additional funding to support things that they really do need. So it is a really strange tension associated with this, but it's clearly a financial construct. And where this relates to architecture in particular is about the investments that might be available for developing a new hospital or a series of clinics or an ambulatory care center, or wow, this population's growing here, but we don't have really robust healthcare architecture. Let's go plant a flag. And oh, by the way, another system might also be looking at that same data and decide that they want to plant the flag. Well, this is something from the Federal Reserve that illustrates that from the run up to the pandemic, from let's say the end of the recession, we had a fairly steady state of fairly modest cost growth. And this is the producer price index from the Federal Reserve that is relatively predictable and sustainable. But we hit a point soon after the pandemic where it rose almost 16% per year. Wow, everybody's 401k should have experienced something like that, right? The sustainability of that was completely out of question. So what we can see from this chart, and this chart was updated just last month, so it's fairly current data, is that it's leveled off, but it's starting to bump up again a little bit more. This matters because ultimately it's the sustainability of the health system's finances that will allow or forestall any kind of development of the healthcare infrastructure, namely hospitals and other kinds of places like that. So when we talk about these things, let's say we're going to design a hospital and build it, and we've got a starting point of this year. We're going to do this, and let's say it's a 3-year project from the beginning of design to the end of construction. All of that is preceded by months and sometimes years of financial wrangling and how are we going to afford this? Let's issue bonds, or do we have enough cash reserves? Probably not. Can we borrow against certain things, etc.? So there are a number of elements that precede what we normally see during design and what the public sees during construction that ultimately catapults into this. But what this chart is essentially showing is the relatively static nature of the physical plant against all the other things that will churn and turn over in varying degrees with the activities, internal operations of a hospital, or even some external things like technology and climate and other politics, that sort of thing. So you can see that the physical facility is relatively fixed, but all these things continue to evolve at a fairly rapid pace. Now, this creates problems for the facility because it's designed for a particular point in time, and we know that eventually it's going to become outdated. Okay, we've got to put an addition on, or wow, we found some money. We can do a few more things, or we've got to replace the boilers and chillers and the infrastructure and the non-glamorous parts of what this is all about. These kinds of things really do matter to health system executives as they're trying to ultimately fulfill the promises that they've made to their various communities. Let me also suggest to you sort of the state of how we got to where we've gotten here. And this is Abraham Flexner, a name that I'm sure nobody knows unless you're in the healthcare space, perhaps. In the early 1910, he published a paper that was underwritten ultimately by Johns Hopkins University and Carnegie Foundation that said all of the medical education that we've experienced in the United States up to this point has been really all over the map, and very little of it is really based in any science. And we can also draw the parallel with ages of enlightenment and the advent of the Industrial Revolution, et cetera. So there are a number of other social factors that were coming into play that sort of forced this. But what this report did was said, look, many of the people that are calling themselves doctors are really snake oil salesmen, and they're trying to profit off of people's diseases. We need to really reinvent how we train physicians. We need to have prerequisites of how they come into these medical schools. We need to really control this. It needs to be scientifically based. We need really clear state regulations around all of these things so that the practice of medicine has a basis that can ultimately be trusted and is predictable. Now, this is a picture. A few years ago, I had the opportunity to lecture at the Royal College of Physicians in London. I took this picture of all these artifacts in this room, and I was just struck by the fact that this existed. In fact, Food and Drug Administration still allows, in the United States, still allows leeches to be used. So some of these things are still artifacts of we think ancient times. This is a very significant piece of architecture. It's the Ether Dome. It's still in existence at Mass General Hospital in Boston, part of Harvard University's School of Medicine. This is the place where the first anesthesia was administered 180-ish years ago, and it was used in surgery. So all of these seats were where spectators just gathered around to watch the surgery in action. This was truly an operating theater. But this was very transformational in the development of how surgeries could happen with anesthesia to eliminate pain or eliminate a number of other severe complications around medical technique. In fact, there's a painting towards the rear of this that illustrates this with a lot more graphic detail, and I'm glad this picture is not as graphic. But this was a significant event that happened in America. Also, during the Crimean Wars, Florence Nightingale was on the front lines treating the war wounded. And what she found was that very few soldiers actually died of their wounds. There were other causes, which are illustrated in this gray here, but what she found was that most soldiers died by preventable effects. Poor sunlight, poor ventilation, soldiers too close to one another, physicians not washing their hands, a variety of different things. So we created this sort of petri dish of disease in these barracks that were supposed to be healing people. So you would think that in the 170 years since then, we would have learned something. Well, the fact of the matter is we didn't. So this is a picture of the Javits Center in New York during COVID. This is exactly the same kind of problem. And this is a problem of federal policy more so than anything else. And we can talk long about that. But I wanted to offer some of these things as a basis of sort of the context of this. This is another phrase that many architects love to talk about. We shape our buildings and then they shape us. And again, the context of Winston Churchill's remarks were about the reconstruction of the Houses of Lords and Commons, this bicameral form of government that sort of shaped him as a statesman as they went back and forth to negotiate various policies and laws. And ultimately, his point was, yes, we must rebuild this. But in the context of this, he was also talking about his development personally, negotiating between these various houses to get things done. So all of this is sort of shaping something that I want to talk about in a little bit related to evidence-based design. So Roger Ulrich is another name that probably nobody's heard of. But in the mid-1980s, he published a very interesting paper. Roger was not an architect. He was an environmental psychologist. So how does the environment really affect people's perceptions of things and that sort of thing? And he wrote a paper called A View Through a Window May Influence Recovery from Surgery. So there's a very clinical sounding title. And they reviewed a number of patients from a Pennsylvania hospital that had experienced surgeries. And this was over many years. They looked at a variety of records. They assigned patients as they needed to. What was interesting was some patients had a view to nature and others had a view to a brick wall. Just the wall on the other side. But what they found was really phenomenal. The people that had a view to nature had shorter post-operative hospital stays. They had fewer other complications and fewer complaints to the nurses. And they used fewer pain medications. He published this, and those of us in the healthcare space sort of sat back and said, this is very interesting. Is there more to this? So one of Roger's collaborators and colleagues, Dr. Kirk Hamilton, who just retired from Texas A&M University, where Roger also had taught, ultimately Kirk coined the phrase evidence-based design, which has a corollary to evidence-based medicine. So this is the echo of the Flexner report from the early 1900s. So that's kind of the context of all of this. And this is why most healthcare practitioners are really interested in this kind of design.
That's interesting. Just the example of the window. From your experience, what other techniques and what other lessons have been learned about that impact recovery, impact less pain, a more pleasant environment for the patient?
If you'll allow me to kind of go off on a tangent here. So you may remember this commercial from the 1970s, and some of us, it was an interesting commercial in many ways. It was a Tootsie Pop commercial. So this kid's wandering through the woods, and he has a legitimate question: how many licks would it take to get to the center of a Tootsie Pop? So he asks all these various animals, and he comes to this owl, and the owl takes 3 licks and chomps it. Ooh, 3. Well, there were some people that decided that they wanted to actually find this out. The engineering students at Purdue University concluded that it took 364 licks to get to the center of a Tootsie Pop because they made a machine that simulated the licking. Because they were also students and they're really into this, and Tootsie Pops are fun to eat, they did it, they just did it manually. They came up with a completely different number. So their Big Ten rival, the University of Michigan, okay, well, we're going to build a better machine. And they came up with a completely different result, 411. And then a group of middle schoolers decided, we're going to try this. So they came up with 144 licks. There was another university in Kentucky that said, well, let's introduce other variables like, well, maybe color matters, maybe the wrapping or the intensity or the temperature matters. And they came up with yet a different answer. And then there were some other math students at NYU that developed this really complex formula, and they came up with something completely different. So the variation in the variables is 7 times. So it begs the deeper question: how many licks does it take to get to the center of a Tootsie Pop? Well, with 7 times variation, the world may never know, right? I only bring that up because it's sort of a humorous anecdote, because we all sort of participated in that kind of research anecdotally. But let me run through some examples of where some of this research actually does matter. Julianne Holt-Lunstad is a researcher at BYU. She did a study about 15 years ago about social connection. And what she found was, and the punchline of all this is, being isolated from people is actually worse for your health than smoking a few packs of cigarettes a day. Let that sink in for a second. Okay, well, architecture either brings people together or it separates them. So we've got some dynamics at play here. She also, just a few years ago, authored on behalf of the Surgeon General's office, and this was right after the pandemic, after everybody started talking about loneliness and separation and that sort of thing. She authored this work on what loneliness really is and its effects, again, on behalf of the Surgeon General. There was a study that was done that illustrated that if you have access to nature over an extended period of time, and the study period was about 20 years, regular access to nature, greenery, that sort of thing, you will slow your epigenetic aging, which is the natural aging process of your body, by 2.5 years. Meaning access to nature actually is regenerative, or it reduces or it increases your life. This is a very interesting study. So this came out just a couple years ago in long-term care facilities. So it was a 200-bed long-term care facility. And they changed out the cool white fluorescent tubes with programmable LED lights. And the program was set to mimic how the sun moved throughout the day, how it changes color and intensity throughout the day. And frankly, each day is different. Each hour is different throughout the year. So all of this is programmable, right? what they found was a statistically significant reduction in falls, 43% reduction in falls. Now, if you're a long-term care operator and you have to, somebody fell, they probably broke their hip, we've got to take them to the hospital, we're on the hook for all this, there's a big operational mess, not to mention, but the person's actually injured. They might spend some time in the hospital, then they come back. That's a big mess. So for what they calculated a $1,700 per room fix, they made this problem go away. Now, this is in long-term care. This is how it was demonstrated. But what would it mean if you had programmable lights within your home that were actually matching the circadian rhythm of the sun? How we were actually designed to be. Is there something there? Of course, this requires additional study, but these are pretty significant kinds of things. So getting back to the work that we were doing during COVID, again, in the long-term care space, and long-term care is actually interesting because people that are occupying long-term care facilities are generally a little more frail from a health standpoint, and we can study them over a longer period of time than we can in a hospital, which hopefully they're in and out and from a hospital. But in a long-term care facility, they could be there for a few years. This was a study done in Canada that represented how few people actually lived in hospital or lived in long-term care facilities, but the disproportionate number of deaths associated with it. Now, these are correlations, they're not causations necessarily, but it begs deeper questions associated with that. And there were old types of facilities that had multi-bed wards, et cetera. And then there were newer types of facilities that were more akin to like a neighborhood model, individual rooms clustered in neighborhoods, and the disproportionate number of deaths of this old style of facility. And again, these essentially doubles the risk of death. Okay. These are some other things that are kind of interesting. And again, around the science of control is what we're calling it. If you put stripes laterally across a corridor with somebody that has dementia, early stage dementia, or some sort of cognitive decline, they'll consider those steps and maybe a little less cautious about going into them. Well, all you have to do is put some stripes in front of a door and you can keep people from trying to get out of a memory care unit. But the research says that if you put stripes the other way, they can navigate that and essentially get out of the space. There was another study that a colleague of mine, her team did, relative to remembering instructions with words versus pictures, especially those that have some sort of cognitive decline. The pictures are a lot more memorable. This was also interesting. Just a little contrast in the dinnerware forced people to eat more. One of the things that almost everybody dies of eventually, if you live long enough, is malnutrition. I just stopped eating. Food doesn't taste good, that sort of thing. It doesn't interest me like it did when I was much younger. But what they found was that using red plates as opposed to white plates, the result was that people were taking in more food and more nutrition. Again, these are environmental variables that we do as designers have control over. This was another thing that's been widely discussed. Elderly people or people with less than optimal eyesight will perceive dark mats on the floor as holes and just avoid them. So these are some of the research that's really fascinating.
That really is fascinating. That leads me to the question, hospitals and clinics and doctors' offices are quite often very sterile, impersonal, imposing environments, places that are less than welcoming at a time when you might be going through some of the worst times in your life. We as architects designed these spaces and created them. So why are so many not as welcoming and as supportive as they could be?
Well, let me share some images with you of recent award winners from the AIA's Academy of Architecture for Health over the last few years. These are juried submittals of beautiful architecture that actually hits on a variety of qualities. Number one, It's got to be a beautiful piece of architecture. It's got to function well. It also has to contribute meaningfully to energy reduction, water reduction, meaningfully contribute to health as a building itself, not just the activities that are going on. So this is a hospital in Venice that was done by one of the Florida-based architectural firms. And it's a beautiful piece of architecture. I'm just going to run through a variety of these to demonstrate that it doesn't have to be cold and impersonal. The problem is we've got a lot of healthcare architecture that already does exist. Campuses are seldom just renewed just because. They're renewed if you're going to consolidate two hospitals into one. They're going to be renewed because they've reached their point of obsolescence in that the care models that they were originally designed around are no longer applicable, that sort of thing. But most healthcare architecture is about additions and renovations. The American Society for Healthcare Engineering, for example, which is part of the American Hospital Association, on an annual basis publishes what kinds of projects are coming up, what kinds of projects are you likely to be doing over the course of the next few years. And most of these are renovations. These are just brand new builds. And again, these are opportunities to do some really cool things. These are a collection of ambulatory care centers, which generally do not house inpatients. These are also acute care hospitals and clinics. But as you can see, these are beautiful places. They have fine architecture, and they vary. These are from across the country. The first one was from Florida, so we're really proud of that one. But there are some perennial firms that appear to just have a magic of how to win these. These are sensitive to the aesthetic qualities, how patients experience and family members experience. So if you're doing a pediatric hospital, for example, sure, you have to make it kid friendly. But it's not just the kids that you have to satisfy, because the kids are accompanied by the parents who are making decisions about the care for their children. And if you're doing a children's hospital, for example, it's not just about primary colors, which are necessary in early stages, but what about a tween or an early teen? They're not all that interested in those kinds of things anymore. So you got to design for a fairly wide audience in that regard. These are fairly complex buildings technically, and the emerging science around the application, some of the things that I shared before, how spaces are perceived, the neurological implications of them. A number of people are now looking into behavioral health kinds of spaces and what the implications of those are, whether or not they're calming spaces or intentionally agitated kinds of spaces. How do you deal with patients that present at an ED where, if you're the director of an ED, an emergency department, and you don't know what's going to come through your door? You got to be prepared for everything. In some cases, there are underlying psychological issues, etc. So you've got to be able to deal with a wide gamut of these kinds of conditions.
Sitting here thinking about the healthcare industry and the mergers of hospitals and these large corporate structures who kind of dominate some of the hospital industry. Your margins are tight and your bottom line is important. Are you finding that these larger organizations or larger corporations are receptive to all of this these studies and are willing to spend the extra dollars for good design and to create those beautiful buildings you just showed us?
Well, ultimately, yes, but the evidence around this needs to be accompanied by a real dollars and cents value proposition. And architects used to be good at that. Now, so much that we've sort of outsourced a lot of the authority and the responsibility to others, we've sort of dulled our collective professional sense. And I think that there are a few of us that are trying to get that back. Nonetheless, modeling some of these things from a financial standpoint is absolutely important. There are some health systems, especially some of the for-profit systems, that require more than a 3-year payback. We're not even going to consider. 3-year payback is a fairly short period, even if you're doing a building that's going to last 60 or 70 years. So who's going to model those kinds of things? Well, we might be able to find somebody that could do that. There was a study that I reviewed for a professional journal early last year that was essentially asserting ways that you can connect those dots together. And again, this happened to be in long-term care building typologies and a variety of approaches to those, but connecting the dots of why you would invest in a certain typology versus another typology based on the return on investment. I would suggest that those kinds of studies are beginning to emerge, but they're not nearly as mature as what about the lighting? Well, what about the textures? Or what, all these other things that we're beginning to learn. So this is a developing collection of science and applied art, really.
Isn't that the role that we, as architects, believe is our wheelhouse?
If it is, then we got to claim it. We've got to demonstrate it. Now, it's interesting. There are some great architects, and then there's some that are minimally competent, according to the state. And there are some great attorneys, and there are some that are minimally competent. There are some great accountants, and some that are minimally competent. Some great doctors, and some that are just minimally competent. So it is about choosing the best ones and developing some sort of rubric and asking these deeper questions about, well, what do you know about this? Or what have you explored about this? And not being subject to the jargon of something that they just heard at a conference a few months ago. But, let's dive deeper into this. And there's a lot to discover, and certainly nobody knows everything, but this information is available.
That leads me to something that I know that you have done recently. In 2024, you successfully submitted and steered a resolution to the AIA Health and Welfare Policy, which is palpable considering your career promoting health and well-being through architecture in your whole entire career. How did you come about forming WJH Health, which is dealing with all of these issues, and then explain the breadth of the impact that resolution has on architecture in the society?
It kind of is two very different questions. I had worked with firms for almost 30 years and enjoyed practicing in firms, enjoyed doing projects, and enjoyed the people and those kinds of relationships. And we did very interesting work. But I had an opportunity to just jump out and do my own sort of consulting, because I found that there was a gap between what the executives are thinking about and what the architectural machine is geared up to do. And I thought, maybe there's an opportunity here. So I just took a chance and talked with a few former clients, and they said, yeah, just go for it. I think that there's something here. So I did that. And that was 13 years ago this month, actually, that I launched this. And it's set up as a sole practice, but I've got a number of friends across the country, so I could pull people in as I need to. So I don't have to carry a lot of people, but we can get some things done that we need to. So things related to deeper financial modeling, or if I need imagery created, or a variety of other things that I could sort of direct, but I don't have to directly do. That's the nature of the initial business. But even that has evolved over the last dozen plus years. At this point, I'm doing a variety of other things. For example, this research team that you mentioned in my intro, we've been around as a team for 6 years now, doing a variety of things in an interdisciplinary kind of way. We got a couple architects, we got a couple bioethicists and physicians, and we're talking about these bigger ideas essentially on the weekends. And we write about these things, and we've now just developed a way to commercialize it, because we've got a process to evaluate design as it's happening. And we've done that successfully on a few projects already. That's sort of the nature of what I'm doing now, which is different than, you hire a firm to get a project done because you've got a deadline, you've got a budget, you've got operational expectations on the backside of this for how the building's going to serve your enterprise, and those things are absolutely necessary. Mine's sort of running in parallel with that. But it was because of the nature of what those things are, coupled with the findings of this research, that I started asking some deeper questions. I had the privilege of being elected by the AIA Florida to represent Florida at the American Institute of Architects Strategic Council from 2021 to 23. Each year, the council identifies some key elements that they want to research, and we come together and we do that. The last year I was on the council, we made a strategic choice to focus on the nexus of architecture and well-being, or the architecture and health. And we made a conscious decision as a team not to just do another study to confirm what everybody generally has already known, but to really shine a spotlight on the evidence that does in fact already exist. And there is enough evidence to make it compelling. For example, the Center for Health Design is a separate organization from the AIA, but it's tied to it through its Academy of Architecture for Health. They have a knowledge repository of 6,600 or so peer-reviewed studies. The nature of the peer review is either a juried project or it's kind of a deeper dive, double-blinded study kind of thing. But 6,600 studies as it relates to architecture's effect on health, and most of this is in the healthcare space, admittedly. But that's nothing compared to the 38 million articles that are on the National Institutes of Health PubMed site that researchers and physicians are constantly looking at to develop and refine their practice and care protocols. So it's maybe one to 6,000. I mean, it's so vast, the difference between these things. And admittedly, some of those are about, how certain cells metabolize certain proteins and that sort of thing, which really have no bearing in architecture. But there are other things that are related to the sciences of color, or perceptions of light, or how certain qualities of light affect neonates, premature babies, effectively, even before their eyes are fully formed. So there's a lot of deeper science around some of these things. So this information is accessible, and we have tools now, AI-enabled tools, to do some deeper searches to point us in a variety of different directions. So our abilities to offer excuses, oh yeah, I just didn't know about that, are starting to wane. In fact, I was talking with a dean of a law college a couple of years ago, and he was asking me questions like an attorney might ask, well, what do you know about this? What could you know about this? Then he leans in, what should you know about this? And it really amplifies the deeper import of what our profession can bring and arguably should bring. So what I'd like to do maybe is share a little bit about the journey associated with the resolution in 2024, which was the year after I rolled off to the Strategic Council. But I'd like to offer sort of a preamble of what the American Institute of Architects had done maybe 10 years before. They had formed something called the Design and Health Leadership Group, which studied a variety of approaches to enable health. Let's have a real discussion around environmental qualities or social connectedness or other kinds of things, sensory environments. And ultimately, that led to a publication of sort of a, if you don't do anything else, do this kind of thing. This is why this is important. This is additional research that you might be able to uncover. And it was, these kinds of things require a longer period to really sustain them before it becomes part of standard practice. And the AIA had a variety of other priorities at the time. So an outcome of the Committee on the Environment was something called the Framework for Design Excellence, which included design for well-being in its matrix. And it's got a number of elements associated with it as well, including a toolkit. But these are all sort of suggestions. So during our study year, we asked some fundamental questions of some leading researchers, some of whom are very well decorated architects. All of these people had either a single or multiple doctorates in some sort of health related field. And what we found was really profound. And that led to the points of the resolution, which were supported by a variety of organizations, the General Services Administration, the Centers for Disease Control and Prevention, Blue Zones, several universities and others in the Academy of Architecture for Health, the American College of Healthcare Architects, the Construction Owners Association of America, etc. But it was a simple 4-part resolution that basically said, we can't ignore this any longer. And if we do ignore it, that's an ethical issue and that's on us. We got to stop that. Number 2, we've got to deepen the framework for design excellence so that it's not just suggestive, but it's more prescriptive kinds of language. The AIA as an advocacy organization needs to be out talking about architects' role in contributing positively to health and healthier spaces. And then lastly, we've got to really bake this into our educational processes and get students in early. So that's kind of how these things really came to be.
The more I hear you talk, and we've talked about this offline several times, I don't think anyone who's not an architect watching us today has had knowledge that what you do for health, what architects do for health, design of healthcare, is so deep. Involves so many things that are psychological, technical, influential, economic. It probably of all of the, I think of all of the podcasts we've done so far, this is probably the deepest and most complex architectural solutions that we've talked about. And your work is so research-based and so data-based. I think that's a testament to our profession, a testament to what we do and how we do it. One of the things that you just mentioned is that the part of that resolution was to get our universities and our educational system informed. And as you spoke, that was one thing that came to mind. How do you communicate all this research that it seems to be fragmented and pieced in very much pieces? Now, granted, AI can help us coalesce all of this. But how do you see in the future our educational system and AIA and organizations like ourselves focusing these studies and this research and these techniques to better solve healthcare architecture?
Well, I think it comes down initially to a choice. This matters or it doesn't. There are a variety of distractions. There are architects that just like to do McDonald's restaurants and Wendy's restaurants, and nothing against McDonald's restaurants or Wendy's restaurants, but they're fairly simple and direct, and they can make a good living doing that. Why should this matter to me? Why does this matter to my clients? And in some cases, it may not. But if you can exert a discussion around the deeper qualities of why this does matter and the global benefit associated with this for your client initially and your client's client, because everybody's got a boss. Every business has customers. Every firm has clients. So how can you create a higher order of value, which is really the point of of the resolution, it was a value proposition as much as it was anything else. And the General Assembly approved it with an overwhelming supermajority. Everybody got it. So how do you distill this? You've got to keep talking about it. It has to be part of the common rhetoric. Late last year, I reviewed a book called Architectural Epidemiology, which sounds really kind of eggheady. And it's a thick book. It's 300 something pages. And I agreed to do it before I saw how thick it was. But it was beautifully written. It was wonderfully laid out. And it was sort of a how-to book for policymakers, for designers. It's written by Adele Houghton and one of her colleagues. Adele is an architect. She's a fellow in the Institute. She's also got her doctorate in public health. She teaches at Harvard's School of Public Health, the Chan School. She and one of her colleagues wrote this great piece. I would argue that everybody needs to read it, and it's a great book. There was another friend of mine who a couple years ago, 2024, published this book. This was after he had a successful architectural business and he continues to practice. He went back and got his master's degree in neuroscience and is now pursuing a doctorate in public health. His idea is, a pithy quote, there's no such thing as neutral space. Every space either contributes to or detracts from health. Sort of like saying there's no such thing as neutral food. Either food will make you healthy or it won't. It'll contribute to disease. All of these things are choices that we've got to make, and we've got to be very deliberate about it.
Well, I think you're absolutely correct about the value proposition. Healthcare costs. If you can just reduce the stays in hospitals and reduce the amount of drugs and care necessary for a patient to recover, that's a value proposition right there. So if you can make that point, I think that would be not only a value proposition, but those who have to spend days in a hospital and going through procedures would see that as a big value proposition if the architecture could get them out of the hospital 3 days earlier.
Well, the battle isn't necessarily in the intellectual assent to those ideas. But if you watch television, you see tons of commercials from drug and the money is in chronic disease treatment, not in I just had a motor vehicle accident, or I broke my arm, or I blew out my knee playing tennis because I'm 70 and I thought I was 30. Those kinds of, it's in the chronic disease management, it's in heart disease, it's in diabetes, it's in a variety of other things. So there are certain non-allopathic ways of reducing the effects of those or reducing the inflammation associated with some of those diseases. But it's fairly easy to go to a doctor, he prescribes a relatively simple and inexpensive drug, and that cycle just keeps continuing and continuing and continuing. So it's really an economic issue. How are we going to upend an economy and create an alternative value proposition? And that's for people that are much smarter than I am to figure out. The bigger idea associated with how we as architects behave in the content that we're bringing forward, any reasonable physician would tell you, you got the same thing that your mother would tell you: eat your vegetables, don't eat so much ice cream, all of these kinds of things. So as responsible architects, we have to be bringing these kinds of things that are only good for our clients.
Well, Bill, thank you so much for your time, and it's been a very interesting discussion, and the amount of research and how deeply you dive into it is very impressive. You should be proud of what you're doing.
Well, I'm proud of the smart people that are around me. I don't know who said it, but surround yourself with smarter people and you'll do much better.
Thank you, Bill, for your continued efforts in promoting design excellence in the healthcare space, and for bringing to light the many aspects of well-being we architects should consider, like the evidence-based design. I find that really intriguing. Oh, and congratulations on your 13 years in business.
Well, thank you. Thank you.
Yeah. Stephen, thank you for your efforts in bringing the series to our public and hosting the episodes with us. Thank you for listening to this episode of Architecture and You. Stay tuned for future episodes as Stephen and I explore examples of why architecture matters, what architects really do, and how good design can improve our lives in ways we might not expect. This is Rhonda Hammond, AIA, your host of the Voice of Florida Architecture, a podcast of AIA Florida.